Welcome everyone. We are live with another episode of Level Up Law, where every Tuesday at noon, South Carolina Legal Services is leveling up your legal knowledge about an area of law that we practice in. I am Senior Staff Attorney Susan Ingalls, here with our producer Kenneth Elliott, and you are viewing live Teresa Skojic, Mental Health Services Manager at the SC Safe Seniors Program out of the College of Nursing at the Medical University of South Carolina. We are so delighted to have you on our show today, Teresa. SC Safe Seniors does great work with our seniors in South Carolina, and today I know you're going to be sharing information about your program and also discussing the psychological impact of abuse on older adults, and that's just so important. So thank you for being here. As we continue to observe not only Older Americans Month, but also Mental Health Awareness Month, I think this is just a great combination subject for our viewers. So important topic for all of us to know more about. Before we get started, we do want our audience to know that this is not legal advice. It's just general information for the public. If you do need the help of a lawyer, you can call our intake line here at South Carolina Legal Services, or you can just apply online 24/7. That information will be provided at the end of Teresa's presentation today. Also, as a reminder for you, all of our episodes are posted by our wonderful producer, Kenneth Elliott, to the Level Up Law playlist on our YouTube channel, usually within about 24 hours. Now, Teresa has said she can answer general questions if time allows during today's presentation. So do put questions that you might have in the question box here, and we'll make sure that she answers them if time allows. And just again, be sure to check out our social media in addition to YouTube. We are on Twitter, Instagram, LinkedIn, you name it, just go to SC Legal Services, and we'll be providing all kinds of information and resources all the time. So good stuff for you to be following. So without further ado, that's enough information from us. Welcome, Teresa, and thanks so much for being here. You take it away.
Thank you, Susie. Very excited to be able to share about this today. So as Susie mentioned, we're going to be talking about the psychological impact of abuse on older adults. And I'm going to give you a little bit of information about our program. So we are a two-pronged program, and we really try to focus on education for the healthcare providers and then an option for an intervention. So this is really our model. So first, we do training and partnership with local healthcare providers, organizations, anyone who is interacting with an older adult in the community or in their home. And we try to train them on some of the things I'm going to be going over today with you, but also about what to do if you do discover that someone is currently being abused or maybe has a history of abuse. And then we offer services. So everything that we do is free of charge. We are funded by the Victims of Crime Act. We just applied for our 7th grant year. So it's been a lovely, we've really seen growth in the referrals. So people are actually doing something and are referring to our program, or even just referring for some other help. So it's nice let's talk about some numbers. Why are we doing this? So there was a study completed in 2010, which now feels like ancient data, but what they found, so this was the National Elder Mistreatment Study, and what they found is that 1 out of 10 community residing as adults over 60 has suffered some type of abuse in the past year. In South Carolina, our prevalence is actually higher, with about 15%. It does align with the rates of domestic violence and family violence. But although, and we always say these numbers, I take them as our starting off point, because this is not really reported. Only at 1 out of about 24 cases is reported to the authorities or reported to anyone. Older adults often will experience emotional mistreatment, and I'm going to talk a little bit about the different types of abuse that we go through. And people with lower social support have a higher chance of their first victimization or continued victimization. We also know that it's higher, about 50% of dementia patients have been a victim of elder abuse or mistreatment. In South Carolina, persons 65 or older make up about 18.2%. And again, that statistic is from 2019. So obviously that number is most likely higher as people are moving and just aging in South Carolina. We do see that there is, for females, there's a lower median income than males. Some of that is because of years worked. So their SSI is going to potentially be lower. And that we do see that as of 2020, again, that's right when the pandemic was beginning, 9.5% of adults 65 and up live below the poverty line. So these are all people who potentially have increased risk for victimization. So let's talk a little bit about the different types of abuse. So I will right off the bat, I'm going to highlight this, that the most common type of abuse is psychological or emotional. Often that is involved in order for the other types of abuse to occur. So psychological abuse may be things like gaslighting, purposefully isolating the person, and that could be using their words like, oh, no one wants to see you. No, that's not happening. You're just going to embarrass yourself. It may be manipulation, anything that doesn't leave a mark on, say, your finances or your body, but really can shift our ability to function in life. Physical, this is also one of the hardest ones, as most of you probably know, to prosecute because we don't have any evidence besides what someone is subjectively telling us. Physical abuse, that may be using restraints. It may be actually physically hitting, slapping someone, causing physical pain or impairment. It could be holding people within a space. I've even seen people do some physical abuse with food and other medications. Verbal abuse, again, would be using words to humiliate, to shame, really raising your voice, saying very pointed things. So the psychological sometimes is more undercover. It can be, it makes you question, is that what's happening? But verbal abuse is much more overt. Sexual abuse, which does happen with older adults, is any type of non-consensual. So we would definitely say that it would be the same as any type of sexual abuse. It just also can be coupled with the physical and the psychological. Financial abuse has 100% been on it's been in the news, it's been in the forefront. We're seeing it happen with people who are older, people who are younger. When I talk in the community, I say I get attempts. You know, I have student loans and I get prompts that say, oh, you're in default, even though I know I'm not. And what really happens, why financial abuse is usually able to happen, is that it's actually psychological abuse as well. It's triggering you to get into a panic state. So you make decisions without sound judgment. You're in that fight or flight mode, and it's not necessarily your best way to be thinking clearly. And then lastly, neglect. This may be someone who they're just actively refusing to help care properly for someone who they are a caregiver for, or it could be that it's not purposeful, but they're very overwhelmed. They don't have the proper training. They don't have the proper resources. So sometimes we see neglect. Any of these can be, not any of these, some of these. So I would say the psychological, physical, and verbal, as well as neglect, could potentially be signs of a caregiver who is not equipped, not supported, and is experiencing some burnout. They might not be purposeful. They might, so, but sometimes they are. Sometimes it is someone who is actively attempting to abuse. So what do we see? What are some signs that someone may be currently being abused, or it may have just recently happened. We'd call this like the acute phase. So first may be low mood. That's something we would associate with depression, where they can't really report or remember the last time they were happy. They just feel down. It's not necessarily being neutral, it's truly just down and dragged and just feeling very low. They may choose to increase their isolation. This may be a safety behavior where someone has harmed them, and so they're going to sort of scuttle in and stay away. They may also do this out of embarrassment because they don't want anyone to know that this thing has happened. For someone who has been verbally, physically abused, you may see an increased startle response. So something that would quote unquote not be alarming, like, oh, I walked into the room and you clearly saw me, they may still jump. Things, a loud noise, they may have an overactive startle too. If someone is I'm from the north, sometimes I talk a little bit louder and with a little bit more gumption, and that could be overwhelming to someone who has been recently verbally abused. And if you knew this person beforehand or even around the abuse, you may see the gradual change. Sometimes there might be thoughts of death, and it doesn't always have to be true suicidal ideation. They may not have thoughts or plans to actively kill themselves, but it may be things like, it would just be easier, or if I didn't wake up tomorrow, that would be okay. It's not really fear of death, it's more this new acceptance or seeking out of death, even if they don't actually intend to harm themselves. I mentioned avoidance. Avoidance is one of the things that we see the most from people who have experienced trauma. Abuse, any type of trauma, but definitely abuse, because avoidance is great. It makes us not have to feel the bad feelings anymore. But what it really does is it can hold us back from getting resources and support that we need, and also keeps us stuck in this space of harm, of shame, and it really does not do people service. And another one, I like to call it use of negative coping skills, but we may see people increase their drinking, increase their cigarette use, if they do use illicit substances, like say they smoke marijuana, they may increase that. Say they have prescription medication that they were previously using as the doctor prescribed, they might start to abuse it. Even some people who exercise can become a negative coping skill if you are overly utilizing it in a way that is unhealthy or affects your functioning. Eating, sleeping too much, eating too much, not eating at all of those things, they have a reasonable purpose. Someone having a glass of wine, that's reasonable. But if all of a sudden now they're drinking mass amounts and they say they're able to verbalize that it helps them relax or it helps them not think about things, those are what we would call negative or dysfunctional coping skills. So after trauma, not everyone develops symptoms associated with PTSD, depression, anxiety. Sometimes we truly do naturally recover. So right after, in that acute phase, right after a traumatic event, say someone, a history, a long period of abuse, or even a one-time experience, someone calling and trying to financially scam you, that is going to be upsetting. It's going to shift the way that you act and the way that you feel. That's normal. If you just got into a car accident, you're not just going to walk away and be like, I'm okay. You're going to have some time that you need to sort of fit that in, process it, and recover from it. So we expect people's functioning to shift after something traumatic has happened. And then about starting around a week to maybe 6 weeks, that's when we may see a gradual return to how they were previously functioning. If someone had that really significant startle response or was very avoidant of things, that you may see them start to turn back and go back to how they used to be, but maybe with some new knowledge. They may shift some of the things they do, but it's not dysfunctional. And it's not like 6 weeks and they magically are back to the way they were, but you want to start to see some recovery around that point. That's usually actually some of our trauma assessments. We want to know from 6 weeks after what's been happening. And so for others, it's been 6 weeks, nothing is shifting, things are actually getting worse, then that's when we're going to say, you know, recovery is not happening. Natural recovery is not happening. They're going to need some support. They're going to need some treatment. And that's when someone like my program could potentially step in. I will say it can be very helpful to get supports during this 1 to 6 week time, so that they don't fall into this bucket of continued symptomology, right? So sometimes we do see these early interventions can be really helpful right after a traumatic event. So it's not to say leave them be until 6 weeks. It's just sometimes people will just recover naturally without it. But usually it's because they have some supports within their life already built in. So that was all general trauma. So let's talk about older adults. So older adults have lived a longer life. They have more of an opportunity to have experienced several little T's, which we say are small traumas, things that might not completely shift your functioning, but have an impact, and then big T's. So that would be being abused, being assaulted, being financially exploited and having half of your money being taken away, being in a significant car accident. All of those things would be considered big T's, but that is still a very individual thing. So something that may be a small trauma for me, maybe a big trauma for someone else. But we really want to think about this as sort of a building block. So say as a child, someone lived in a home where there was a lot of domestic violence, and some of it was pointed at the children. So we would call those ACEs, adverse childhood events. And that is going to impact how their belief structure, how they see themselves, how they see the world, and is going to start to build on how they cope. What are their coping skills, whether they are technically negative or dysfunctional or positive and functional. Then we get to our adulthood. That's where we may experience more interpersonal violence. We may experience domestic violence firsthand. As a child, maybe you witnessed it, and now it might be something that you experience yourself. You may be a victim of it. You may, you may experience a mass trauma. Things like 9/11 are considered a mass trauma. COVID-19 is actually considered a mass trauma. Things that a lot of people find traumatic. It's like a big group trauma. In adulthood, you might also experience workplace trauma. If you are a firefighter, an EMT, a doctor, a nurse, a social worker, a lawyer, where things are happening and you are sort of experiencing it. Some of that could be vicarious, where people are telling you their trauma and it sort of sits with you and slowly shifts the way that you do things. But again, this is another instance of where our beliefs either are being reinforced. So say from childhood, I created a belief of all relationships are violent. That might be the belief that has come into my head. And then as an adult, it's confirmed because my romantic relationship is violent. So now that's my belief. And it either gets confirmed or maybe it gets challenged a bit if you experience things that are either good or bad. So say your childhood was great, no adverse childhood events, but then in adulthood something happens. That's challenging those beliefs before. And again, your coping will change. And now we're in our old age. So we've potentially lived through all of these things. We might have experienced a fair amount of small T's, small traumas and big traumas. And now as I'm an older adult, what if my support system has changed? Potentially my spouse is no longer around. Maybe my children are no longer involved in my life. There's actually a term I heard recently. It was elderly orphan, which I thought was something that I see, where children just aren't really engaged with their parents the way the parent really hopes they would. And so now as an older adult, things that you've sort of carried and coped with, then something else happens. You get re-victimized. And so all of this stuff could come flooding forward. So say someone has experienced, domestic violence and that sort of emotional abuse, that gaslighting, things like that. And it happened in their childhood and it happened in their sort of middle adulthood. And then they've coped with that. They've done whatever they can to survive in this moment and to be functional. And then as an older adult, say they experience someone trying to scam them, and that floods back all of that psychological abuse, all of the things that they'd experienced before. So they may have a reaction that is larger than what you would expect because there's all of this history, there's all of these other things that are similar tied into it. So it's really important to consider sort of the path that someone has walked and the ways that they have adjusted and found to get to this point. And then what else is happening for them? Is this a person who is also dealing with a lot of health problems or injury? And so their resources are very tapped. I call it their emotional bandwidth is already at its max. They kind of can't take on more. That may also change their reaction, the way that they're able to cope or not cope with whatever has just happened. As I said, each different experience with trauma, it does build this reaction of the others. And yet the degree of recovery from those original things, as we talked about in the last slide, some people naturally recover and they're okay. But if people are still sort of in this limbo space of having symptoms and they're just carrying them and just sort of trying their best to survive with them, the last thing that happens in their old age, this next trauma could be the thing that sort of makes it all unravel, and could really push their ability to cope with it. Before I'm going to kind of get into some symptoms, any questions about sort of that cycle of trauma before I move on?
Teresa, no questions yet in the chat box, but or the question box, I should say. But we do encourage our viewers or listeners to ask a question if they have one as you go along. So
great, thank you. So I think it's really important when we talk about older adults to acknowledge that some things look like the other. So when we talk about dementia, for example, dementia is very scary. People are very scared of dementia. And often if there's an older adult who seems confused, has issues with memory, we immediately are like, they probably have cognitive decline, which is possible, right? Should that be something that they get referred, is to get a mental status exam from a provider? That's probably a really great idea. But those could also be symptoms of anxiety. They could be symptoms of depression. They could also be symptoms of PTSD. People who are anxious and are engaged in a fair amount of worry and cognitive processing may have a lot of difficulty making decisions. Their bandwidth is stretched to the max. We also see memory loss can be a symptom of PTSD, where their brain has sort of done this thing where they're going to block out, it would be very specific to the trauma, where they're going to block out what happened there, and it's a protective measure. Changes in mood or irritability and anger, that can be a symptom of of dementia. It can also be a symptom of a UTI, or it could be something that maybe they've experienced trauma and they're having these symptoms associated with that. We also see changes in appetite and true changes in locomotion, how fast or slow they're moving, that they're able to process information. Speech may even slow down, and that all could be depression. If someone's is speeding up, that could be more of that anxious behavior. And then changes in sleep. Again, there could be medical things with all of these, but it also very much could be that they're having some sort of psychological impact because of the trauma that they recently have experienced. I love to talk about this cycle of anxiety. It really is an avoidance cycle as well. Um, and this is how people get stuck with these traumatic experiences and their responses, is that we have this anticipatory, so we think something is going to be scary or dangerous or make us feel distress. So, and we don't like that. We don't like to feel bad. We don't like to feel distressed. That's just how beings work. So then they avoid them. Oh, I'm just going to stay inside. I don't want to have to deal with that. Oh, I'm just not going to talk to that person because I don't want to have to talk to them about this because it's going to make me feel distressed. And they feel great. Oh, God, I didn't have to do that. I don't have to feel bad. But the problem is that it reinforces that this thing is scary and bad, and it really makes our symptoms get larger, and then the response gets bigger. You can imagine, like, there's a small crack in the ground, and you're like, oh, I don't want to, just in case, I'm going to stay away from that. But the more that you stay away, the bigger and the bigger and the bigger this crack grows, so all of a sudden you have this chasm, and it feels impossible to pass. And that's why sometimes people who've experienced a fair amount of trauma and have sort of pushed it down and avoided it will find it very hard to talk about it, because it's like they have to build a bridge to cross this chasm. And that could be with new traumas as well. So that might be why people don't, that's part of the reason why people might not report and might be very limited with what they are willing to say about what they've experienced. So one thing that we suggest, and this is one of the things we train our healthcare providers for, but anyone who is dealing with an older adult who is potentially a victim, could be to screen them. And that could be through just open-ended questions. Do you have everything you need? Are you feeling safe at home? Is there anything you wish that you could have that you don't right now? Questions like that, just to sort of prompt the person to me, and it feels a little bit, say, you're not openly saying like, have you recently been abused, because that might make people shut down. But how are your relationships? Do you feel you're getting the care that you want? Things like that may, and I know for lawyers, again, if you're asking, something has happened, right? So even sometimes in my clinical work, I'll say, I would like some information about this. You don't have to tell me everything right now, but can you please share what you feel comfortable sharing at this moment? And that might be a good way to start the conversation. And then as there's comfort and as there's rapport, you can start asking more like pointed questions. But really, I sometimes say, I would love for you to be able to tell me this from your words. You could also use validated questionnaires. There's a lot of them, so they've been tested. There's evidence to say that yes, they do assess for what we want them to assess. And then lastly, there's your judgment. There's your experience. You may observe the person and say, well, that behavior seems like something may be going on. We're not going to make a snap judgment and say, oh, yes, this is definitely this or that. But it sort of gives you want to put it all together and say, okay, well, this is what I'm seeing, and this is what they're saying. Does this match? Does it seem like there's more happening? You may also be assessing for need. Do your caregiver has been accused of abusing you? Do you need help getting a new caregiver? How can we support you through this? Because do you need referrals to your local area agency on aging? Do you need to assess for vulnerability? And I know when it comes to APS, and there's, APS doesn't deal with criminal there, but we got to kind of make sure all of our boxes are checked in that respect. But you might need to ask the client, what they need, what could help them during this time. And then you might, and if it feels appropriate, if it's within your normal way that you practice, offer some referrals. If it seems that they are really struggling emotionally, you might see if they're interested in mental health services. You don't want to push it. Just, I know this this group. It is free, so that relieves the burden of paying, relieves the burden of insurance. It's through telehealth. You don't have to drive. Would you be interested in talking to them? I could give them your number. And again, maybe making referrals to their local area agency on aging or any other resources that you know of that can support them during this time right after the abuse has been founded. Okay, so again, a little bit about our program. So this is a good referral. This is a good intervening moment. All our services are free. Everything we do is free. We don't need insurance, which can be very difficult. I will say one of my hills that I will stand and scream from forever is Medicare is very limited what providers they will reimburse for mental health services. I am a licensed professional counselor. I cannot bill Medicare. So the only way I can see my patients right now is to make sure that it is for free. And there is a significant lack of providers who, one, can bill Medicare, two, are accepting Medicare patients, and three, don't have an extensive wait list. So I'm going to be completely honest, there can be some barriers when it comes to older adults receiving mental health support, but that's sort of the gap that we try to fill. So it is myself, and we do have master's level interns from the Citadel. We do telehealth statewide. I do have some patients in the Low Country that I have seen in person, and that's sort of a one-off basis. It's more the exception than the rule. And then we really try to focus on supporting their symptoms and trying to get them restored and really focusing on them. We're very person-centered. And we can include wraparound services. So, you know, if someone needs referrals, needs help with things, you know, we have people who, I had a patient one time who really needed dentures, but couldn't get into the MUSC clinic, and I had to look to find, and I was able to find them a place that they were able to go for free to get that work done, and it significantly shifted their quality of life. We do use evidence-based trauma treatments, and I'm going to explain those a little bit just so you have the knowledge of that. And it's not cookie cutter. We really try to focus on what these patients need. And we want them to be heard, and we want them to feel like I'm not telling them what to do. This is a very collaborative process. We say 55 and up. We have definitely gone below 55. We've gone as low as 50 because honestly, age, again, can be very subjective. There are some people who are 75 and we would say that they would fit into a criteria of a younger person. And then we have like function wise, and then we have people who are 50 and their functioning would be on par with like a 90-year-old. So we really try to be thoughtful about that. They do have to be a resident of South Carolina. And we say experience at least one episode of abuse or neglect within any time. It doesn't have to have been reported. It doesn't have to have gone through the legal system. It's just, if they say that they've experienced it, we believe them. That's really our stance. People can self-refer. Anyone, if you know someone that you're working with that you think would benefit, you can always send me their information with their approval. I do want them to consent to being told about them. And then I take it from there. I contact, I schedule, I handle everything else from there. This is my contact information in case, but we're going to go into a little bit more in a second. Am I doing one time? Okay. So I love to talk about who is our typical patient. Most of our patients are living in the community. I have worked with a few that were in residential settings. Some teaming up with the ombudsman to do. Others were people who I was working with in the community and they transitioned to residential, so that's not an exclusion, but the majority of our patients do live in the community. Most have multiple traumas that they've experienced across their lifespan, and sort of at this point in their life, a lot of their resources and supports are starting to go away, or something else has happened that sort of shakes them and brings all of this back. So they're seeking support sort of later in life. The majority, we really do, there's actually literature that suggests this, but we really see a mixed presentation of depression and anxiety. Not all, some people do meet criteria for PTSD, but it's a lot of, they don't fit everything for depression, they don't fit everything for anxiety, but you see this like mix of the two. We also see that there are a lot of complicated family relationships. As I mentioned, that sort of orphaned, that elder orphan. So it's either there's weird communication or it's just disconnected, but there's something about the family structure that is contributing to their trauma experiences. As I said, they haven't quote unquote dealt with it for years. I've had so many people say like, oh, it's been so long, like I should just, live the rest of my days like this. And we say, no, you don't have to do that. Especially because we know that living and with those symptoms actually increases your risk for being re-victimized. And then we also see a range of technical competency. I like to put this in because we do telehealth and some of our patients are like, oh, I don't know how to do that. You know how to do that. I will help support do that. We really take on that I wear my IT hat every now and then, and I can help people, and we have lots of ways to make sure they're getting their services and connecting with their clinician. So we support all of that and try to help in the ways that we can. Sometimes with giving iPads, cellular enabled iPads out, so that's video visits can happen without the older adult needing to have home internet or a smartphone or anything like that. So we do have that option to offer those things. So I'm going to give you a crash course in trauma treatments because I think it's interesting, but I think it's good to know so that so you know what's happening. So what we would call general talk therapy would be supportive, where someone gets to come in and they vent about their time and their day, and the therapist sort of can help frame things and help them work through these emotions. That would be very supportive. It could be stabilization, it could be working on coping skills, it could also be helping get resources. We do some of that. Some of our patients need that before jumping into more of these specific trauma treatments. So prolonged exposure is one of my favorites. It's really originally was made to work with veterans, but it works for anyone who's experienced trauma. And I talked before about avoidance. Prolonged exposure makes you confront your avoidance. It makes you face the things that you believe will cause you distress, that you believe are dangerous. And a lot of times we see that those beliefs start to spread out and become very general. And instead of the specific thing that's happened, all of a sudden anything that could ever be associated or similar to that event is now dangerous. So it works to expose to the actual incident, the memory, and then it also works to expose to things in their life that they might be actively avoiding. And that's 10 weeks that we do for prolonged exposure. Cognitive processing is 12 to 14 weeks. Again, evidence-based, which means it's been tested. They say it does what it's supposed to do, and it is helpful. Cognitive processing is more for people who maybe aren't actively avoiding things as much, but have a really skewed view of the world and themselves, and it's all related to the trauma. And so it really tries to help pull back some of those beliefs to be more neutral instead of very extreme. We see a lot of black and white thinking. Things are good or bad, they're safe or not, and really trying to help them come back to more of a neutral stance is what cognitive processing therapy is. Behavioral activation is really for depression. Sometimes we work this into some of these other treatments, and the purpose is to increase our activity. People who are depressed stay depressed because depression is very reinforcing. So we try to do the opposite. We try to get them up and out and doing things. And lastly, cognitive behavioral therapy. This is another one that's evidence-based that can be used to treat depression, anxiety, can kind of be coupled with that supportive, but it really is about figuring out our dysfunctional patterns, I like to call them habits, that really tries to create change so people become more aware and are able to make those changes. And as I said, these aren't you know, you either get this or this or this. Sometimes we mix them together. Sometimes we start with supportive and then we move in. Sometimes we start with behavioral activation to get someone up and ready to do some of these, because they take work. It really takes work from the victim, from the patient. So we like to make sure to set that precedent and tone and let them know that. So we might need to do a little bit of supporting and getting them up and out before we get into these things. And that's it. All right, we have time left.
Well, Teresa, that was awesome. And I think you did such a great job. We don't have any questions in the question box, but you know, we've got a few more minutes as we look at your contact information and all the people that you work with. This is such good information for people who are serving seniors or even who have seniors in sort of that family or friends category. It's so important to know this and to know what you guys are doing there at SC Safe Seniors. This was really a great way to find out what you guys are doing and to really see how that's evolved over, did you say 7 years?
We're yeah, we just applied for our 7th grant year, so we would find out in September if we'll be funded for our 7th, which fingers crossed. We've been going for a while, so.
Y'all are doing great work. But so yeah, thank you so much. It was an excellent presentation, and I do want to remind our listeners that if you found this helpful, I'm sure you did, and you know that there's other people that need this information or it's going to be helpful to them. I know I learned a lot, and I have older, you know, folks in my life that this was just really, I was definitely zoned in because of that, and because we serve the elderly here at South Carolina Legal Services as well. So I do invite everyone to go to the YouTube channel tomorrow at SC Legal Services because it's really important that you go and share this broadcast with people that you know can use this information. We want as many people as possible to learn more about SC Safe Seniors and about the psychological impact of elder abuse and how groups and programs like SC Safe Seniors are helping our seniors and what they're doing to address some of these problems. So definitely go check that out. While you're there, of course, like, subscribe for more, ring that notification bell so you'll get that notification every week when we post a new episode. We know that everybody can't be here live on Tuesdays at noon, and we always appreciate it when you are here with us on Tuesdays at noon. But also we have a lot of folks who go and look at our recordings, and we're already getting people saying thank you and great presentation. No questions though for you, Teresa, but I'm sure we'll all think of them as soon as this is over, because it is a lot to digest, but really such great information. So we really want to thank you for such an excellent presentation.
Thank you. And I just want to say at the very end, if you're not sure, right? If you have someone and you think, I don't know what to do, I'm not sure how to ask these questions, you can always call us and just talk to us about it, and we can definitely give some suggestions or advice or just bounce some ideas off. That's one of the things we love to do. I've had many victims advocates call and just say, I just need to talk about this person and see how I can best support them. So we're available as consults as well, if that would be helpful.
That is so wonderful, because I'm sure, I know I do, and other people have just those little burning questions. You're like, how do I find out what to do about this? And that's so great to know that y'all are open to that. I do want to this time tell our listeners that here is all of our contact information here at South Carolina Legal Services. You can apply online anytime, and our intake service by telephone is open Monday through Thursday, 9 to 6, and we encourage you to apply either way and find out if you're eligible to get some free legal representation. We also have all the information about our resources here. We put out a lot of content that we hope is a bit, helpful to people. It's always available, and we're doing more and more stuff all the time. In fact, Right now, we're working on our second round of online classrooms to help folks learn about how to represent themselves in court. So hopefully that's something that can be helpful to folks. So again, thanks, Teresa. We want to tell everybody in the audience, thanks to you for tuning in. We really appreciate the support that we get from the viewers. And be sure to tune in next week for a final Older Americans Month episode of Level Up Law on Tuesday at noon. Thanks again for tuning in, everybody, and thanks to Teresa Skojek of SE Safe Seniors.
Thanks, Susie.
Take care, everyone.